Thank you for coming. You're at the third session of MyHIN's Data of Advanced Care Planning workshop. Thank you so much for sticking around, and thank you really to the people who have gone through the series. Wow. Let's move it along. I'm going to tell you why you're here. Well, I'm going to tell you a little bit about like why I'm here and who employs me and what we're meant to do. Next slide, please. Oh God, this is the slide. You can see me. My name is Joanne Jarvie. I'm the Senior Director of Outreach and Market Communication. If you have any questions about what you hear here or what you see online, or if you don't know who to connect with at MyHIN, or if you generally just want to know what the haps is happening, please write to me. I'll put my email in the chat. That's why I'm here. I'm like a traffic officer. I'm going to send you to the right people. I only know what I know, but there are other people that know more. Thank you for letting me speak. Next slide, please. The Michigan Health Information Network. We are Michigan's state designated entity, a nonprofit that was created to help disparate entities within the health and wellness sectors share information. And we do that legally, we do that technically. We want to do it meaningfully. We want to not only, I think we're in a new phase here of health information exchange where it's sort of like the data is moving, which was a big push, but now we need the data to be super meaningful, and we needed to not overwhelm, and we needed to get to the point. So that's what we are here to do. Next slide, please. We are a neutral data steward. That means that we must act and protect and collaborate around this, this sense of data. Like, what is data? I think data, first and foremost, should be information. And it should be information meant to communicate something. We should be using it to find out something, to make a better decision, to see more about a population, to find out more about a patient in less time, if we can. And certainly we should always be asking, why are we trying to communicate this? Why are we sending this information? And who said we could? And who else said we could? And who can we share it with? And how does that make a care team? I think it's important to make sure that also that MyHIN is focusing on the most impactful activities that it can be for our participants and for our state. Next slide, please. Certainly, the goals of health information exchange are reduced inefficiencies. We really want to try and make things easier, faster. We want to improve healthcare access. We want to make it so that there's lower costs, better outcomes, of course, more and more personalized medicine for patients. How can we take better care with the right information and the right context to that information? That's why we're here. Next slide, please. So it's kind of interesting. We have a lot of stakeholders. We have a lot of participants in different areas of the ecosystem. And it is what we do with our sort of interoperable data fabric between these parts of the sector and between these disparate agencies that really pushes our work forward. I think what people don't necessarily understand is just how much information we have flowing, just how many participants we have, just how much how much we are looking to connect and build out the network. The stronger the network, the more impact and meaning it will have to each of its participants. And more on the ground, social workers and patients themselves are going to want to understand why health information is being exchanged, for what purposes, with who, and within what context. And we want to do that at scale for the full state. So these are our stakeholders. And these are, these are stats. Next slide, please. Essentially, we work as like a hub and spoke model. If there were not a statewide entity, nonprofit, collaboratively governed, responsible for connecting everybody, that would mean that everybody had to make every connection to everybody else. And it's just not efficient. It just doesn't work like that. Certainly not now, guys. We're growing up. It's time. It's time to work smarter. And that's what we're here for, certainly. Next slide. I want to introduce you to our team. If you guys have been here, you know them already and you've come to love them. They are going to, they're going to really work with you to make sure that they heard you, that we are responding to our stakeholders, to our participants on behalf of their patients. Lisa Nicolau is the director of cross-sector data sharing. She has red hair and she's Canadian. She is also a nurse. She is also a project manager. She also cares deeply and really tries to get to the point. Lauren keeps us all organized. She keeps this project moving, and we couldn't do what we do without her. And Van is sort of like the more technical guy. This guy goes in, he takes what he hears and he tries to code for it. So he's one of those. But we need everybody on the team. We need people that are looking at this from a clinical perspective, from sort of like how will it work perspective, and also how will it work technically perspective. And they are here for you. So I am going to hand this over at this point. Like I said, I'm going to put my email in the chat. Please bother me. I mean, somebody talk to me, for God's sakes. Thanks. Next slide.
Just so you're clear, if you don't talk to her, she's going to bug you. All right. Thank you guys for joining us. This is number 3. Okay. I don't suspect that we're going to need the full hour and a half. So I'm hoping that we can kind of move through this. I want to remind us and what we're here to do. So the purpose of this specific convening one, the first session was really a level set, understanding where are we at, what the national kind of landscape is looking like, and really kind of get on the same page. There was some literature in that, there were some videos, there was some really great conversation that really helped us to kind of come together on kind of where we are at, so that during the second and third session, we can kind of figure out where do we want to go, and determine kind of like what might success look like for us here in Michigan. What are the metrics, both short-term, medium-term, and long-term, that we might be able to use to change the care of individuals going through serious illness. And what is available in the state of Michigan for advanced care planning facilitator and conversational training and leadership, understand what that's environment and what's needed going forward. What documents, what data, what information must move in those care environments, what the role of MyHIN really can and should be, and whether or not there are policy barriers that really should be addressed in order to streamline and make the most efficient human and technical processes. Next slide. So as we go through this, I just want to level set on so we're at the stage of, we think we heard you. Our goal in this is to kind of put forward what we think we heard those recommendations really should be. We're going to give you, we don't want to assume, and we don't want to leave it to kind of narrative comments. We're going to release some polls. After each one of these, we're going to release a poll. You're going to have an opportunity to engage in that poll. That way we can collect the quantitative data that allows us to really kind of substantiate what we heard. And if there's in some of those polls, there will be comments that are allowed to be fed into it. Any questions about kind of how we're going to navigate today and what we're looking to do? And at the end of it, we can kind of maybe summarize and just say, okay, how did we do on this? Are we good? Did we hear you? And is there anything else last minute that should be said? So are pretty clear? Everybody good? Give me a thumbs up if you're with me. I'm sorry, I don't even see I have to scroll down to see if we have seen everyone. Okay. I'm seeing some thumbs up. All right. So let's go on. So the first thing that we heard and the first recommendation is that MyHIN's advanced care documents use case efforts should prioritize getting patient advocate designations signed and exchanged. Next slide. What we heard that brought us to that conclusion is that in that current state, the patient advocate designation is the most impactful, legally binding piece of information that delivers value to clinicians. It mirrors national findings. It mirrors the fact that living will documents in current form does not hold value or accurately reflect choices in serious illness conversations. Doesn't mean that we should stop receiving them. If people want to send them in, we will do that. They will be available, but our focus and our effort for the time being will remain on patient advocate designations. That there is some potentially new formats that are coming through that can help capture people's value wishes, but they're not really in a standardized format. They're not agreed upon, and they're not in wide use as yet. That there's maybe some changes that need to be managed that could hold better value and translate an individual's desires in a different way. Again, MyHIN does not intend to exclude other advanced care documents, but we are going to focus our efforts on patient advocate designations. And that the quality improvement processes include data and measurement to drive decision-making. MyHIN can provide some level of program and data measurement to help drive that level of decision-making. Next slide. This was kind of a quote from the notes that we captured. Anything that doesn't, sorry, I have to move my, that doesn't create movement towards patient advocate documents distracts us. Patient advocate designation documents distracts us from that work. So at this point in time, I think we're going to release the first poll. Oh, there it is. Have at it. Go ahead. And whoever's monitoring polls, you're going to have to tell me when you think it's time to close the poll. Maybe if when you get done, you can just give us a thumbs up that you're done.
Answers are still rolling in, so giving it a couple more.
It's fine. I want to give it as long as it takes. We've got plenty of time. If you've completed it, just go ahead and give us a quick thumbs up.
Like some folks are typing in the long answer text as well, so just giving maybe a little bit longer for that.
For sure.
Since it's a little bit longer to type out than to just click a button. But
Sure.
things are still rolling in a little bit.
Just while we're waiting, this is Tracy from Covenant, and I know Summer had brought this up at our last meeting that, us being a palliative care team, do agree that patient advocate designation is a priority, but that the conversations about treatment options and including some of that for patients with serious illness, there is definitely still some benefit.
Sure.
So healthy adults, priority on patient advocate designation. Patients with a serious illness need further exploration.
And I think you'll see kind of some of the recommendations coming further to really help articulate that. So I appreciate your comments.
All right, it looks like we have slowed a bit, so I'm gonna end that poll. Would you like me to share the results?
Sure.
All right, let me know if you can
Okay.
see that.
I can see that. Can anybody else? And boy, I would love it if we just come off mute and just talk, because I can never manage comments and such. I see it. I see that 94% of the folks who voted agreed, 6% disagreed, and there's a couple of longer answers there. So great.
And can you see the longer answers? I'm not sure if
I cannot see the longer answers.
okay, if I have like a view details, so I can read those out. One of the ones say, not sure what use case efforts mean. The conversations are important, ongoing documentation of those, as well as a valid legal patient advocate designation. The second comment was, isn't the signed agreement what will drive decision making in a crisis? And then the third is, along with located designation in the medical record.
Okay, great. I think that we can move on to the next slide. Thank you, folks, for taking the time to feed those comments in. So recommendation number 2 was that we could, MyHIN could explore, or whoever could explore with stakeholders, the feasibility of using electronic signature capture on patient advocate designation documents. Not to say that it's ready to go, but we could explore that. And the reason we're putting that recommendation forward is because we heard, next slide, that witness signatures in paper format can be challenging and can lead to lengthy periods of time for completing the document. We heard a couple of different estimates in terms of how long it takes for people to get those signatures captured, given the fact that decision makers may not be next door, they may be elsewhere, they may live quite a ways away. So technology exists and is widely in use in healthcare and other industries for legal signature capture, that it might be worthwhile exploring whether or not that could be used in this situation. Next slide. This was a quote that came from a clinician, and I'm not going to bother reading it because you can all read. And at the same time, we're going to go ahead and release that poll. I feel like there should be music playing or something. Otherwise, I feel like the need to talk, and that's bad.
And just giving it a little bit longer, some responses are still coming in, mainly in that write-in option. So just trying to give it a little bit longer.
Great, no worries. Thank you for the thumbs up. Greatly appreciated if you're done. Great. While people are finishing up, any comments, thoughts on this one? And just jump off mute and join the party.
Yeah, so Lisa, this is Mike. I actually, both of these questions to me are a little bit challenging because it might be a yes, but, or yes, and, or yes, but maybe depending on what the next recommendation is, I might have more to say. So I'm wondering a little bit about whether we should quickly see what all the recommendations are and then go back and vote. But the other one for me is, to me, and I hate to comment on it until people have voted, but for me, this is not enough. Right? It is feasible. It's just not allowable. And it's not feasible for everyone, but it's feasible for enough that those who are able and willing to move forward should. And if we explore it, we'll be exploring it for years and not moving forward. So that's the only reason I voted no.
Sure. It would be interesting to talk with you further about that. For sure. And we can have that. We have enough time if we want to have like other thoughts on that. Happy to do that.
I have some worries about this. This is Amy. I think it's important that individuals consider and reconsider their preferences as their health changes, as their other things in their life changes, such as their caregivers, their patient advocates, what's going on with them. And I think that communication with their patient advocate over time is important. I get worried when we have preferences for care and a medical record without the assurance that those reading the medical record understand that they still need to get consent for care from the patient advocate. We cannot work independently on these preferences for care. We're getting consent either directly from the patient or the patient advocate. We're not guiding our plan of care by looking at these preferences for care. We're having direct communication with those that can consent for care for the patient if the patient cannot.
So this really only applies to the patient advocate designation.
So being able to change their preference for who their patient advocate is over time? Is that what you're saying?
Like,
okay.
Meaning if we can kind of expedite the ability, take away that barrier for some people to be able to get a witness signature and get more patient advocate designations on file and available to clinicians so that they know who to go to. So agree that, understanding what treatment preferences and things like that are still important, but this recommendation really only applies to something that is not going to change as frequently.
But we'll still need 2 witness signatures. Anytime you change your patient advocate, you have to have witness signatures again. Okay.
Sure.
Because a lot of times when I hear preferences, people are talking more about treatment preferences. They're not talking about preferences for who's consenting for their care.
Now, this recommendation was specific. Explore with stakeholders the feasibility of using electronic signature capture on patient advocate designation documents.
And I think too, just to add to that, I do agree with what Amy was stating. But as I'm thinking, boy, if we could just even get this okayed for electronic signature for the patient advocate, okay, we can still do the witnesses in person. But if we could at least, at minimum, get the patient advocates, it allowed to have patient advocates sign electronically, because many people have their children who live out of state.
Sure. And
I
again, it's not,
wholeheartedly agree with that. Yes.
and again, this recommendation is to explore it. This is not, let's implement it, let's explore what it takes.
And just making sure you can see the results right now on screen.
I clicked them away, but they
Oh, that's
were-
okay. I was just gonna read off, there were a few write-ins, and I know you said that you can't see those on your end, so
Sure.
the write-ins were not just explore, it is already feasible, just not allowable. Advocate for making it permissible and allow those ready to move forward to do so. Second comment, we can e-sign everything these days. Last comment, agree this is worthwhile to explore, but really do not think this will be that much more advantageous overall.
Okay. And again, this is our recommendations, moving up the chain of command to figure out what can and should be ultimately done. This is not my hand going forward with something, or we don't even know if that's really ours to take on. It's really just that there was a barrier and there was a potential a technology solution that could potentially impact that. Any other thoughts before we move forward? All right, let's go on to the next one. I'm gonna, I want to be able to go through them, but I feel like we'll lose our cadence. So I'm gonna keep going in the thread, but then we, at any point in time, we can kind of come back and capture verbal feedback. Dr. Zarukian, to your point of, wanting to kind of see what the rest is to depend on how you move forward. Does that make sense?
Yeah, I mean, if there's plenty of time, that's fine, but
Yes,
as we heard early on, somebody had a question and you said, well, that'll be addressed in another recommendation. Well, we could hold our questions if we knew what all the recommendations were first.
Sure.
That's all.
Sure.
But if we have time.
And it's no problem to kind of have the conversation. The more conversation, the better off we are. All right, so recommendation number 3, statewide licensing requirements for mandatory serious illness conversation continuing education credits may be a viable solution to help standardize and level set on kind of what that new pathway is. So it could come into those licensing requirements. That's one conversation that we remember. The reason we heard that go forward is adding on serious illness conversation for physicians, nurses, and applicable care team members might create a standardized level set for what documents are legal documents, what the goals of it, the new information that's coming through, maybe changing vocabulary, that type of thing. Similar to the same way we wanted kind of that there are standardized education. I'm a nurse. I know that I have to have a certain number of credits in pain. I have to have a certain number in trafficking education, patient safety, so on and so forth to meet my licensing requirements. The same could be said if this is an important level set that needs to be had. Next slide. I can't remember if we had a quote from this.
No quote here, Lisa. We're just
quote.
going to the poll.
All right, so I guess we can go ahead and release the poll. when you're done, if you feel like kind of a comment, that's great. How are we doing there?
Just giving it a minute to see if anybody was still writing in, but it looks like we may be good on this one.
Great.
Well, I will end this poll and share those results.
So 92% agree, 8% disagree.
And the write-ins were reasonable and will likely be seen as too burdensome to provide, or to some providers, and unnecessary for those who already do this well. There is no end to what we could consider so important to mandate.
Okay. Any verbal thoughts? All right, let's move forward. Recommendation number 4, we discussed kind of Michigan's lack of a next of kin law. So a Michigan, the recommendation we're putting forward is that a next of kin law should be investigated as a policy lever to support serious illness, end of life care. And the reason we are putting that recommendation forward, always, we want a patient advocate designation. But in that instance that a patient doesn't have an advocate, the current law may leave a patient without a decision maker. And while the lack of a patient advocate or a lack of a next of kin law is really intended to protect that individual's wishes and make sure that they have autonomy, in some spaces that is actually causing direct harm, such as delayed care. There are spillover unintended consequences that create a significant legal burden on the families, hospitals, states, payers, etc. So trying to balance it out, not that we have the answers, but we're hearing that there's a lot of unintended consequences in here, and in some cases, really causing direct harm to individuals. Did we have a quote on that one?
Nope. Moving on to the poll.
Okay, moving on to the poll. As people are finishing up, any thoughts on this?
I disagreed and I didn't comment. And the only reason I disagreed is, because I think I do agree with this, but I think, the other things that were being proposed take priority. The other suggestions for focusing on.
Okay,
I'll agree with priorities, but I just think this is another thing worth exploring. I know I've talked with other providers in other states. And they've utilized this quite well. I've done some national meetings, so it'd be worthwhile to see what other states maybe have done and how successful, or, look at the good and the bad about
Yeah.
having that kind of a law. But I've heard a lot of good things about it from other states, other providers in other states.
and again, just because we put a recommendation forward doesn't mean that it won't be uptaken. It's really just to be able to say, these are options and allow others who are much smarter than I am, to advance this, if that's so desired.
Dr. Zarukian, if there was a state that you'd like to see us explore more, so could you name one? Would you?
I think it was Texas.
Or I'm sorry. Okay, thank you.
Yeah, I think it was Texas.
Thank you, Oris. Sorry about that.
I guess I worry about who would be at the table, who would be invited to the table to help create this policy, how this policy would morph and change. I would always want, if we do have a policy, that it would allow the first choice is whoever the patient names as their preferred decision maker, not default to some blood relative, because I've encountered too many individuals for whom that would be the worst person to make their decisions.
Sure.
Yeah, I agree. I've seen it happen a lot too. Yeah.
And those are caveats that we can capture and put forth with that recommendation. So please, that's great.
It's also largely the reason we asked for a patient advocate in writing, so that the patients expressed preferences rather than what we might
Yes.
otherwise guess take precedent.
Very agreed. Very agreed. All right, 83% agree, 17% disagree. And we heard the one comment about just a priority. Others, Caitlin?
Yes, so where did I just go. All right, so the other comments were along with education about the process for guardianship and court-appointed decision makers. And then the second one was, but seems hard to implement and keep updated as families change more rapidly these days.
So I think this may be part of the exploration, but I think this is exactly the situation we're talking about. Somebody didn't go through the process of codifying their preferences, and therefore we are left with word of mouth, and that's it. And so that's why it is such a tough law, if you will, to put in place. But without some kind of a standardized approach where we have an order for next of kin when there is no other document, that's the wrestling match we have to solve, because I think that's where it applies. Anytime we have something written, our problem is already solved as long as it's valid.
Exactly.
Right. First, second, third choice, right?
Exactly. Always preferable to have a patient advocate designation in place. All right, any other comments?
I can comment on this as a former ICU nurse, that oftentimes when we did not have record of anyone or anything on file, we would default to this as a informal policy or way of getting families' opinions. So I'm not sure if you were to reach out to clinicians at the bedside, maybe in some of those more critical or acute areas. I would think that the feedback that we would get would be that they're already doing this in this case. So to have it be, binding or have some legal support in that arena may be nice.
I think that the real challenge with this, because I'm an old ICU nurse as well and an ER nurse, and for sure, a lot of hospitals, and Amy Bailey, keep me honest here, a lot of times within hospitals, you can have that specific policy in place as long as they are in hospital, but the transfer out of hospital, either to a hospice care setting or to a longer term care facility, that's where there's no one to be able to make that decision, because you can't come out of hospital without it. So it kind of leaves people lingering in hospital during when they could be receiving different care in a more appropriate place. Amy Bailey, I'm sure you've got a comment to correct me on this.
No, I totally agree. I appreciate you captured that perfectly. And just to second what Lindsay has to say, let's make sure that we have bedside nurses, bedside social workers involved in policy making. Maybe see what, let's take a review of hospital policies and what's working well and what's not working well.
Agreed.
How are our ethics committees able to help guide us on this too? Because we have several stories to share, I'm sure.
My team, I just want to make sure that we're capturing all those good thoughts, because as we kind of like put those recommendations forward in written, we want to make sure that we capture those nuances that should go with the recommendation.
A comment here, by default, most of the precedent in the hospitals that I've worked in, that the dilemma only comes when the next of kin as a grouping is not have consensus on the next course of action. And then we click into all the legal parts of getting guardianship or an court-appointed decision maker. But functionally, without a next of kin statute in Michigan, it forces clinicians to decide, is this a real consensus amongst family that are present, and how much do they have to dig into the estranged child in Idaho before it's a consensus, and how much do you operate on the apparent consensus of a decision-making process right in front of them at that moment. So I think I'm a strong proponent of a viable and provable next of kin statute in the state. But we also have to have the backups for when it's not working or the consensus is disputed, and then how you move through the guardianship or court system to get the assigned spokesperson that will be listened to.
Great thoughts. Dr. Zarukian?
Yeah, so just to build on that, and I think if I've captured Amy's thoughts correctly, I mean, she may be referring to the same thing David and I may be thinking, and that is that notion that says there could be a set of rules that says, here's the next of kin approach. What I think all of us are probably articulating is, but there needs to also be articulated exceptions. So when everyone knows that for whatever reason, the spouse is not the right person, that exception also needs to be codified. And I think that's one piece of it. The other part that we've talked about on the commission is that notion of what things can we do, including next of kin, when there isn't a patient advocate designated, to get rid of the current demand, requirement, or burden of having to get a guardian appointed. And to the extent that we can do that through this, or expedite the process if we still must, that would be really helpful. Okay.
Forrest?
Yeah, I think that was capped off quite well. The initial concerns always are, I'm working long-term care, and it's always the issue. People come to the hospital and the decision was made, and there's no documents coming to the facility, and the next day they're back to the hospital, back to the emergency room with the same problem, because nothing holds up in the
Yeah.
nursing home. They're all afraid of litigation and other things.
Yeah, all the
So,
back and forth is just harming that patient.
Yeah. Yeah. But everything else was well said. Yeah.
All right. Did we do the poll on this already? I'm lost in where we are. I'm so sorry. I'm engrossed in the conversation. We did do the poll. We did do the comments. So we're moving forward. Let's keep going. Okay. Next recommendation. My Hands Making Choices Michigan training and facilitation program is redundant. My Hands efforts should remain focused on the movement of information and documentation to support statewide serious illness care. The reason we say that is, next slide. There's ultimately a lot of organizations in the state that provide training and facilitation services already. And the role of the health information exchange should remain focused on the movement of information and data in a vendor agnostic way. I'm going to release the poll because I know, because Caitlin told me, somebody told me that we did not have any more quotes. Oris, is your hand still up from previously, or do you have a thought?
That was from before.
No worries. No worries. Feel free to have a thought. Sorry, who's that? Thanks, Dr. Zarukian. As we're finishing up, any other comments, thoughts on this?
So I'll just comment, to me, these seem like either or statement, as if you can't do one without the other, or you. So I guess the question is, well, you'll see it in my comments. My comment will be obvious because I'm one of the no's, but.
Okay. So recommendation number 5 became 58% agree, 42% disagree. If you disagree, explain why. So let's hear some of those thoughts, because I'd love to have a conversation about this.
All right, so I can kick those off, and then if people want to elaborate any further. So yeah, there were a few in here. So first one, unless Making Choices Michigan gets peeled out from under MyHin, then I would agree that MyHin should stay in its lane. Second one, the training is
Can
needed
you say that again?
Oh, I'm sorry.
Sorry, can you repeat that?
Yep. Unless Making Choices Michigan gets peeled out from under MyHin, then I would agree that MyHin should stay in its lane.
Okay.
The second one, the training is needed to assure the data is accurate before moving. Third, data can drive where training is needed.
Okay, hang on. I'm gonna stop as we go, because otherwise I will lose the thought. Read that second one.
The training is needed to assure the data is accurate before moving.
Okay, so the training and facilitation program is about how to teach care teams how to have a conversation about serious illness care. That is the training and facilitation program we are talking about. So question about whoever, if you feel like you're okay jumping in, was that made clear in our comment, in our question?
Hi, this is Tracy, and I think it really had to do with under the first comment that was read out loud here. I mean, if Making Choices Michigan was always the training, it was everything. It really truly was. So when it fell under my hand, you know, that was the lead for this. So if Making Choices Michigan is going to remain under my hand, then yes, it needs to be responsible for the training before moving the data is I guess what I'm thinking. But so my comment of making sure that the training to assure the data is accurate is me and my thought process of Making Choices Michigan being under my hand. Does that make sense? Again, kind of just a different way of saying what the first person mentioned about if Making Choices Michigan stays within my hand. Yes, that needs to be a responsibility. And
Okay.
if it,
I think this may tie in. Okay, okay. I'm following your train of thought. Can we keep going with the comments?
All right, the next one was data can drive where training is needed, improve transitions of care, lower overall healthcare costs, and support other statewide initiatives. Want me to keep going, or you want anything to elaborate on that one?
I would love to understand more about that one. Because I'm trying to figure out how that fits with providing education. So MyHIN in current form taking a vendor specific pathway approach of respecting choices and teaching people to how to have that conversation, how that fits in with data to drive decision making. Just I'm trying to tie those concepts together and understand. Keep going with the comments.
Okay. Next up, we have many stakeholders may rely on MyHIN's program, would want to be sure the premise of redundancy is correct and options are feasible, high quality, and affordable before dropping MyHIN option.
Yeah, so that was my comment. So to me, this recommendation falls into two things. One is to say people can already get all the training and facilitation services they need to do advanced care planning right and document it in a way that comes to MyHIN and ends up being exchangeable. That may be true, but if so, I don't know what that list of training services is. I don't know what it costs. I don't know how high quality it is. And I know that the Making Choices Michigan program has put in a lot of time, effort, and has some good material in it. So I guess to me, the question is the first bullet a fact? And if it's a fact, then how would we say we can, for the long term, rely on these other organizations to provide this training? You can get it from any of a number of them, and therefore MyHIN will drop its offering for this, not knowing myself at least how many people are using it today, and you'll need to use a different source for that. That could actually be a step backwards if what we have is a highly used and highly usable training and facilitation service. But there's no question the focus of MyHIN is data movement, but it's also the right data at the right time in the right format, et cetera, et cetera. So it's a little hard for me to be comfortable separating that out from the training and facilitation services that are also under the same umbrella. Does that help?
And I'm gonna try to dig up the training and facilitation services, what the usage of that was for I think it was over the course of a year or 2 years, to give you some of that information. Amy, you had a comment.
I have a question and a comment, I would say. So I've been involved with Making Choices Michigan since January of 2020, so right before COVID hit. And I want people to correct me, please. I haven't seen a formalized training delivered by Making Choices Michigan, potentially with the exception of when we had her name escapes me, but we had one of our experts on the mental health piece of advanced care planning do a webinar. I believe we had that. What I have seen is it's been more of a gathering place of who's providing specific trainings. Like you could go to the website and see, oh, well, maybe Beaumont's having a Respecting Choices training. But and again, I could be wrong, and I'm sure COVID ruined everything with regards to training, but I haven't really seen it. I'd also like to highlight that Respecting Choices is costly for people to participate in. And I know probably folks aren't going to be happy that I made that comment, but it is costly.
And it's not appropriate for many organizations. For some, it will be.
For some, it will be a great fit for, yes, for others, maybe not. And also, typically it's a full day. And I think we need to really back off from that. A lot of people can't give a full day, but I'll stop talking now so people can educate me on this.
Lisa, there was also a question from Teresa Anderson. Just wondering, does Making Choices Michigan just cover advanced care planning?
Making Choices Michigan was a holdover from Great Lakes Health Connect. And when the two organizations merged, I don't know if there's any way, if any of my team can go back to the slides from the first deck that gave the Making Choices Michigan spiel, because I think that would be really, really helpful as we are kind of having this conversation. But Making Choices Michigan was something that was offered in the very early days of Great Lakes Health Connect. And it was driven by Respecting Choices and adopted. And now Respecting Choices is a vendor-specific pathway of training and facilitation for advanced care planning and an advanced care planning program that was brought over during the merge with MyHIN. And, you know, when you're trying to merge things, you don't want to change everything all at once. That provided for not just training and facilitation, but kind of thought leadership on this subject matter. And trying to help congeal some of the efforts and bring people together to have conversation about it and that. And unfortunately, we have lost our training people. There's no capacity right now within MyHIN. It doesn't mean that there cannot be, but in current form, we don't have anyone with that level of knowledge. That the Respecting Choices training and facilitation takes, again, a very specific pathway. Thank you. There we go. I'm trying to pull this from my memory, and I'm not doing a good job. I'm sorry.
This is David Blau. I was part of the regional steering committee that predated the Making Choices Michigan effort, which was a standalone organization, at least about 4 to 5 years before Great Lakes Health Connect. Mm-hmm. And it then focused a steering committee of stakeholders across West Michigan mainly, mm-hmm. To do advanced care planning. It included all the main health organizations, the healthcare providers and the acute care centers. When Great Lakes Health Connect came in to the realm of Making Choices Michigan, and it aligned with them. It continued on with the Respecting Choices model. That model has its drawbacks, one of them being financial. But it's all the Gunderson lacrosse things, across the nation. But just to be a little history here about the fact that it even predated as a organization to do training and conversation building before Great Lakes Health Connect. That was an effort that took a lot. There was a board, I was on the board of directors of Making Choices Michigan at that point. Just some of the background there.
Sure, thank you. Dr. Zarukian, I think you had specifically talked, and Amy talked about kind of what has gone on in the last 2 years, actually. Over the course of 2 years, Making Choices Michigan trained 66 people in total. It did convene people. It did provide advanced care planning leaders and coordinators a way to come together, and it maintained a system of volunteers to conduct individual advanced care planning conversations within communities. So there were 3 functions of the Making Choices group. The work that we were specifically asking about, if we could go back to the poll question at all. I'm sorry, I've taken us all over the place. My team is now ready to
Lisa,
fork in my eye. Yes, Tracy.
add a little bit on there too. And I think what I remember Making Choices doing, which was I felt very beneficial, is I could remember we created like some statewide terminology, and I think Myhen was involved in that too, or Mahia. And but Making Choices Michigan was a good lead person in that as well. And we brought in some statewide vocabulary list. We had we had conferences, we had big advanced care planning conferences for people to come. So I mean, I know that Respecting Choices was a big model of that, and I'm not 100% sold Respecting Choices, but I do like their model. I think it's wonderful. We are not bought into it fully, but the conference, the ACP conference that took place, and somebody correct me if I'm wrong, if it was not Making Choices Michigan, but I believe that's who really helped start that. And that's been kind of taken away since then. So I think there was still more than what was on this slide here. That was a statewide, yes, they did use Respecting Choices, but the conference was general Michigan user-friendly ACP knowledge that was shared.
So the recommendation here is really just about the training and facilitation. So there may be what I'm hearing is that it may be less about the training and facilitation and more about having a leader, some organization to be able to lead efforts. Is that it? Am I hearing that correctly? Am I surmising that? Whether that's Myhen or whether that's someone else, there needs to be. Okay, so that's good to clarify. Is there anybody disagrees with kind of like that summation? And is there anybody who would be like, oh, I might, knowing that if we're really only talking about training facilitation, would you change anything? And I don't know that we can capture that, but we can capture it in comments. Your recommendation, like whether or not you agree or disagree.
So I'll go ahead and jump in. So I'm, I guess, more than a little confused, and I'm feeling a little bit at risk of either offending someone I don't intend to offend, because they're
no such thing,
maybe, or oversimplifying. But when I think about what training and facilitation is needed I focused on generating a patient advocate and a legally signed document. Not all of the discussion that would be had about making choices in a certain circumstance if your health deteriorates. In other words, goals of care conversations that are specific and dependent on what's going on. But the general principle of how do I designate a patient advocate, and if I feel like filling out more, which is optional, but some documents have it, right, to be able to say, what are my general preferences about intubation and things like that. But I would just separate that, since our focus is on give me a legal valid document that designates a patient advocate that is signed, witnessed, et cetera, et cetera. That's a thing that I've done with physicians and other caregivers in less than an hour. Very focused on what does good look like, and what, if you sent it to our health information management department, would be scanned in and could be used.
For sure.
For that. So to me, I think that's the focus of what training and facilitation would be. I just looked on the, Making Choices Michigan site. It's clearly a course for training facilitators. So it looks like it's maybe a train the trainer. I don't know for sure. And maybe it's way beyond the issue of just figuring out who the patient advocate is. So while trying to respect that, my point is, if we're going to meet the focused main goal of increasing the percentage of valid legal advanced care planning documents that designate a patient advocate that can be acted on, there needs to be training and facilitation associated with that. It needs to be manageable. It needs to be affordable, et cetera. It may well be, and Amy sounds like our expert on what's actually been happening the last few years on it. I would agree, anything expensive, anything that takes all day is doomed to fail. Right. So that part, we just have to have a different strategy. The question is, what's MyHIN's role in that versus something else? And is there another program out there that is reasonable, affordable, concise, that would meet and match our goals, assuming I've captured them correctly, for patients having that kind of a document? Not the rest of it, goals of care, et cetera, because that's a much bigger task over time.
Agreed. And I think, Amy, I'm gonna shut up. Amy, how about it?
I just want to add to what Michael said, that along with creating that valid legal document, but being really critical in thinking about who is the appropriate patient advocate. A lot of times people think it has to be my spouse, my oldest child, whoever. So there's some discussion that needs to happen there. Also, talking to people about keeping that patient advocate up to date on your preferences for care. Because if we just name the patient advocate, but we don't give them any help on what we want, and it doesn't have to be written down, but just helping them, maybe model for them ways that they can have these conversations, key points when they should review this with their patient advocate. Anytime they have a new diagnosis, new hospital stay, just people have to be told that. And I think that's really what I encourage to also be included in a robust training.
In a robust training program, for sure. And I think what we are trying to understand out of this is Making Choices Michigan is modeled under a very deliberate pathway of respecting choices, which may or may not have application to the broadest population, and maybe have that succinctness and that goal. So understanding, again, we are a health information network, what our role in this should be, as opposed to should there, and I'm going to move us to the next recommendation because I think this ties in very nicely. I'm hoping it does. Okay, there we go. Recommendation number, or question, because we didn't get around to talking about this, so it's still a question, is there a need for a statewide entity to drive process change, standardization surrounding the capture of serious illness, values, and beliefs? And that might include, maybe that recommendation could be tweaked to bring together, to provide that thought leadership that it sounds like is still valuable. So what we heard was, and I'm going to realign, that we are focusing on patient advocate designation, but just getting a patient advocate designation signed doesn't necessarily translate to, I understand how that individual feel like values, what their values and belief structure are, that there are emerging things going on. There are emerging efforts to be able to capture that in a different way. That's down the road, but it's still part of translating, teaching individuals to go back to their families and have those conversations. So there's still a process of education and training that goes on within that. That there may be a need to have an organization. Don't know if it's MyHIN or if it's someone else, or if it's, you know, something new that comes along that is not a vendor specific training and facilitation program, but more geared towards congealing efforts. Can you go back to the recommendation? Because I feel like we kind of need to modify this one based on the conversations that we've heard. Oh, is there a need for a statewide entity to drive process change and standardization and guide statewide efforts to, sorry, I'm hoping somebody, I'm just gonna type this in the chat.
So I'm just gonna, maybe for people to think about, I'm worried that we're getting lost in the weeds and going down rabbit holes and maybe not keeping the main thing the main thing. There's all sorts of curves and twists and turns that are part of this. For me, the starting point is a patient advocate. How good that patient advocate is and how well they serve the purpose depends on everything else that goes into both selecting that person and then dealing with the reality of what happens in their role as they continue on through life. And so part of it is that scope question for us. Is our goal to try to do everything possible to make advanced care planning, goals of care conversations, serious illness conversations optimized? Or is that a bridge too far for what MyHIN itself can and should do? And I think to the point, maybe a couple of points going backwards here, is to say, if we can increase the number of advanced directive patient advocate documents that are worth sharing, number one, we help get them so that they're legal in the state of Michigan. We make them as convenient as possible to be able to be completed, and then we move them around. And then all of the, you know, intelligent, dedicated, experienced people on this call and elsewhere can go through that process that says, well, here's what in our hands helps make sure that the right patient advocate is chosen, that it's updated, that the serious goals of care conversation and serious illness conversations happen, because with an with an advocate who's not knowledgeable and kept up to date, it's still not going to solve the problem. But without a patient advocate, we are nowhere. So I'm hoping that we can maybe decide, you know, at this point, how far do we want to go? What is our scope? Because the more our scope is, the harder it will be to achieve the first recommendation.
Okay.
On the other hand, the quality of that, right? The quality of that advanced directive is dependent on everything else that was discussed. So I completely respect that.
Right. So this recommendation that I'm dropping in the chat is slightly modified. I'm not good on the fly, guys. I'm just not good. If this were the recommendation? Orest? Question.
Well, I was gonna say just what Michael said, I initially, even from the first meeting, I was definitely going down these rabbit holes. Yes, ideally as a geriatrician, I like to see all this captured and have all these, serious discussions and values and beliefs addressed. But first step, that's the most important step. And I just agree with what Michael said. If we get that done right, I think everything else starts to flow differently and will improve care. So again, let's not get lost. Yes, this is ideal, but first step is first step, and it's a major step in the right direction. So that very first question we had for a poll is where we really need to work on. That's really the probably questions 1, 2. It should be focus 1, 2, and 3 is that first question we had in our polling here today, which is what you said you just put in the chat.
Which is good, but from the previous conversation, it seemed like there was still value in someone or some entity to drive those efforts forward.
Yeah,
Did I hear that correctly?
I still agree with that. I think that there's still value, but not to lose sight of that first step. It's still critical.
Yes. Okay, Gina, jump on and talk through that.
Oh boy.
Just say it, girl.
Unless MyHIN wants to be the one-stop shop, if there's a benefit with Making Choices Michigan to the training, certainly. There was benefit with Making Choices Michigan to patient education and forms. Well, there's lots of different ways you can document what you want for your patient advocate. The forms can look a little bit differently. Unless MyHIN wants to take over and say, we're going to standardize everything for everyone and we're going to be the only entity that does it, I think that they need to stay in their lane for the operational and electronic piece. Does that make sense?
It does. Teresa Anderson, you dropped something in the chat. Do you want to jump on?
No, that's why I dropped it in the chat, Lisa. No, I just wanted, just for reference, we've been talking about like other advisory councils and committees and work that they do related to advanced care planning and advanced directives. And so I had come across this resource a few weeks back, and I thought it might be interesting for others just to see how it's worked out like with other states and stuff, because I do see that like other states have palliative care advisory councils. And so I was just looking to, I guess, I don't know. We've talked a lot about the whole process, and I do agree too with what Gina had just said, that with MyHIN kind of like staying in its lane. It's like, yep, you inherited Great Lakes Health Connect or whatever you guys combined. And so that Making Choices came along with that. But I think, I don't think that's in the wheelhouse, and it sounds like there's just not a lot of resources available to devote to that. And I kind of feel like it's like we're asking MyHIN to do something that they're not able to provide. So yeah, that's all I had to say. Thanks.
Thank you. All right, so I think the next step is to really kind of put this to the poll. We've talked about kind of, all of this stuff. Let's put the poll up. There's a place to comment in there, I believe.
And I did just want to comment too. I saw, I'm sorry, just David's comment, like when we're talking about like goals of care and stuff, I feel like it seems like hospitals and providers themselves do a pretty good job of, like, when we're talking about advanced care planning. I mean, because it's almost like asking others to take that responsibility for, it's like, I'm trying to like compare it to something. And the only thing I can think of is like, it's like asking, MyHIN to train community health workers for doing SDOH screenings. And that's something that, needs to happen, I believe, with the people, with the boots on the ground, the people who are having the conversations with the patients or clients themselves.
Yes. And let's remember that the second bullet point, which is, it has been proven that documenting specific care the patient does or does not want is not predictive of decisions patients make at the point of care. So the emphasis and the national standard is moving to how do you have better quality conversations at the time that those decisions need to be made. So let's release Gina. I'm sorry, I'm terrible at monitoring chats. Payers and Medicare risk programs are gearing up to drive serious illness conversations faster than before. Okay.
Yeah, so this is Mike. This is where I agree. There's all sorts of forces out there trying to encourage people to do what they already know they need to do, and at least to some level know how to do it. And in other cases, less, right? So there's already been a big, long-standing national initiative on this. There's not a primary care doctor in the world that I know of, at least in the US, who would say, you know, do you know you're supposed to be trying to gather advanced care planning preferences of your patients? They go, yeah, where's the time? Where's the reimbursement? Where's the incentives? Where's the penalties if I don't, et cetera, et cetera, et cetera. So, and if I did, how do I make sure I can access it? And if somebody else did it, how can I make sure I access that? And that's, again, I think where we're focused on is, can somebody just show me that there is one, that it's current, valid, up to date as much as we have, because that's all we have. And where would I find it in my system if I have it? And if it's not in my system, but it's in a MyHIN registry, how do I get there? So, I mean, I think that's part of what we're doing, but the notion of, and that's what we're going to vote on here in a minute, right? That notion is, should somebody be standardizing how we do this? I would say be very careful about that, because number one, nobody's begging you to standardize it, even if you did, right? We just want to inform them, any of the legal valid approaches to getting this designation done, this is what you need to do. How you do it's up to you, right?
So how could we modify, and we would capture this in, in the notes area of it, but if we could modify the suggestion, just take away the idea of values and everything else, and just to drive that process change, because we've had the benefit of 3 sessions of saying, look this is the national effort. That message has not been widely distributed or heard. We've got lots of organizations who are out there, well, I just want to build Medicaid, come on, we've been told we have to do this, so let's go. So how do we take this message and move it forward so that everyone is focusing on patient advocate designations? So how could we wordsmith back up to the actual recommendation? How could we wordsmith this so that it better captures the essence of what we've just talked about?
Well, again, I'll just speak as a primary care physician. The biggest issue is, what do I need to do to do this right? And then, have you made it easy for me to do it right? So that I can both contribute to the pool of valid ones, and I can draw from the pool of valid ones going forward. So to me, that's the place where I would need MyHIN to help. I wouldn't need it to tell me how to standardize the process surrounding the capture of illness, values, and beliefs.
So, sorry, go ahead.
No, I'm just thinking through what Dr. Z said. So
Yes.
thinking on the, what he had said like before too, where's the incentive, or where's the carrot, or where's the stick if I don't do this? I know it's important. So how can we make it easy for them, or just, so if there are, I guess, incentives for this. So we know that there's reimbursement for advanced care planning on its own. And that's like an ongoing conversation, right? Between the, but there's not incentives built around, like, if you're actually capturing that, that advanced directive. And that's where it gets problematic too, because then we get into the whole version control, blah, blah, blah.
Mhm.
So I'm just processing that, thinking it through again.
I'm trying to kind of figure out, okay, we've made these changes. We've said we are going to focus our efforts on patient advocate designations, but we are a very, very small group of leaders within this space. How do we take that and take that message forward? Who does that? Clearly, I think we've heard that it's not necessarily mine, that we have a role, we have a path that we have to follow.
So that's where I'm wondering, and I did mention in the chat before, like you mentioned before too, Lisa, that we're talking about like, not a, like a large, it's a specific population here too, that we're working with, right?
Yeah.
So that's where I kind of come back to like, HCAM or MHA, you know, Healthcare Association of Michigan or Michigan Health and Hospital Association, to get their, I guess, thoughts on this policy / process or recommendation, if that makes sense. If they would be the right ones to weigh in on that, because and provide that guidance. And the Primary Care Association. I mean, I don't know.
Sure. And I think that that's really kind of getting down to who are the right people to invest in this, but who drives that, I guess, is what I'm getting after. What I really want to know is, if it's not MyHIN, who's picking up the ball on this?
So did MyHIN drive the interoperability, the decision to send laboratory or documents to it so it could exchange them, or was that done outside? So again, for me, the issue is, do we need to drive people to the interoperability requirements that already exist, or do we just need to have the vehicle and the education for them to do that, and then have made it easy enough so it's feasible for them to do that?
So
that's technology. I like that. Linking it to sharing the continuity of care documents. That's a really good example.
I'm sorry, I missed that. Can you repeat that?
I was just agreeing with the previous speaker's comments about drawing parallels to what we did with transmitting labs results and CCDAs.
Yeah, so Gina, this is Mike. Yeah, I think you've got it. So the issue is, there's a difference between motivating people to do something. If there is a pipeline by which advanced care documents, you know, patient advocate documents, et cetera, can be sent to MyHIN and then interoperably shared, and it's limited now and it can be better in the future. Some of these are obviously rhetorical questions. Then that's an important focus. MyHIN's focus would be, make it easy to get it to us, make it easy for us to know, is it legal and valid? Because if we're storing something that's junk, we're part of the problem, right? If it's not appropriate. And then make it easy to share or access, either access as a registry or share through an interoperability mechanism. That is the main thing. And at least as a clinician, this is not from my commissioner, you know, perspective from the MyHIN commission, but I think it's what they're craving. It's that notion that says, how do we in our roadmap solve the issue of advanced care planning documents, specifically patient advocate advanced directive type documents, to have a much better penetration in the IT system, and then share that across the state, so that 5 years from now we can look back at it, see the before, see the after, and know that we've made the progress in that focused area. everything else should continue. It's absolutely important. But I think for the MyHIN part of it is that they can take, process, encourage, expand the number of those documents that exist in the system and the feedback they're getting about their quality and usability.
Okay.
Well, I mean, if we're talking about too, like Gina had mentioned, like CCDAs or ADTs or anything like that, those specific use cases and how those were encouraged to be used or adopted. It really came from, you know, initially, yes, meaningful use, but then also it was frankly, it was Blue Cross Blue Shield of Michigan with their incentives with the P4P. So, and that's why I think we have such high participation in those use cases now. But we had the guardrails before, or not guardrails, but we had like the guidance before with EHR incentives for registries, right? And now it's like somewhat, if it's not like required as a condition of participation, like ADTs are for CMS, then it's somewhat voluntary, because sometimes the juice isn't worth the squeeze for some of these places to send the use cases, right? So I guess it is coming back to incentives, you know, as we look at it from that standpoint.
The other part I would just want to comment on is that if we're going to talk about a focused outreach, all of us know that this conversation is best had within families, not provider to patient, not staff member to patient. That's what we do when we're trying to encourage what really needs to happen, which is go home, talk to your family about this, make a decision. Here are the various factors. Amy commented on some of them earlier. And then we're going to have a follow-up conversation about what you've decided, right? So I think the whole issue of education and all that, there's a piece for caregivers, but then there's the piece that's really a public outreach kind of an effort. And so I think I've heard Lisa a couple of times wanting to vote on this. So maybe we should just vote on this thing here, because I'm kind of craving it too, so we can kind of carry on. But the notion of a statewide entity to drive the process change and or standardization surrounding the capture of serious illness values and beliefs, that to me is way beyond the advanced directive. So if I were to make the friendly amendment to it and say, can we vote on, is there a need for a statewide entity to drive the capture of a valid legal, whatever we want to call it, advanced directive? That would be at least a question I could answer.
Okay.
I think I know the answer to the current one, which is no for me. The other one might still be no for me, but because there's already drivers for 70% of us, it's called Blue Cross Blue Shield and its incentive programs. So anyway, I would like if maybe to call the question on it and see where we want to go.
Okay. I'm going to drop in the chat what I think I heard you say. Is there a need for a statewide entity to drive increased efforts to capture patient advocate designations? So when we put the poll up, know that you are answering that question, not the question that's here on the slide.
I can create a new poll with this exact question.
Okay, great.
So it'll just take me an extra minute if you guys don't mind.
And I'm so sorry. Were we using was this a 2-hour? Am I behind schedule? Where am I?
It's a 2-hour meeting.
Okay, good. I'm not behind. Great. Thank you all for your patience on this, folks, and for your great dialogue. We will get this poll up and move forward. Thank you, Caitlin.
All right, let me know.
All right, there we go. How are we doing there, Caitlin?
So I think some folks may have dropped, so we maybe have a few less responses than before, but I think that may just be due to it being close to the end of the day.
Sure.
So it looks like answers have stopped trickling in, so I will end this one and
Great.
share those results.
Okay. Great. 80-20. And if we can read the answers, I go ahead and read them. I think we've probably heard them, but it's great to be able to capture this in a quantifiable way. So thank you.
Yep, there is just a single write-in, and it's I agree with the revised, closer to your lane.
Okay, great. Perfect. All right, that was great. Moving on. Recommendation number 6. Other metrics should be used to evaluate process across the state towards better serious illness conversation. And this, again, this may take us into that other lane. And if it's not applicable, then great. After the conversations that we've had, we talked about it. We considered kind of what other metrics might be applicable. What we heard, things like the number of documents contained in a repository is not necessarily and I would change that with the only metric to drive change in the state. Things like measurement of ED visits in the last 6 to 12 months of life might be helpful to know to measure quality. Further explored of date. Wow, something got lost in here. There were a list of other ones, and I think it's probably in the poll that we created, like other metrics that might be useful metrics to be able to produce to help understand what's happening in that kind of end of life care space. We may or may not. Let's put the poll up. Let's see what.
Yeah, I think it was divided into 2. So I believe the poll that I'm going to launch right now is just a simple yes or no other metric should be used, but then the next one is going to list out those metrics.
Okay, great. And this was based on feedback. How are we doing? This is a pretty easy one.
Going to try to give it another minute or 2. A couple more seconds, I should say, not a full minute or 2, just to keep things moving along.
So I'm like sitting here, and if you see me flashing my office, my daughter closed my office door, and now I feel like I'm in a greenhouse. So I'm like dying here. Whew.
All right, yeah, it looks like we had some people writing in, so I'm glad I gave it a couple extra seconds here.
Thank you.
All right, I think we are probably good. So I will go ahead and share those results.
Great.
And I can read out there was 2 comments written in. And the first is, I don't know that you will be able to land on one metric given that patient preferences can vary. And the second was future focus, would need to examine suggested metrics to agree.
Okay. Great. So the next kind of question was really about what metrics we had that we had heard. And this is really just kind of a series of metrics. Do you agree? Do you disagree? If you disagree, why? And just kind of, so it's going to take maybe a little bit longer to go through.
I don't understand the first question.
I'm not sure that it translated quite.
I don't either.
Like, it's really just trying to understand where we are as a state in terms of palliative hospice physician distribution. As we're starting to look at better overall quality of care. And again, if the whole purpose, if we just have to stay focused on patient advocate designations, then maybe these don't apply any longer. But these were part of the conversations that we had in the earlier sessions.
So you're
How
talking about
many
geographic
alternative-
distribution? I'm sorry. Go ahead.
So meaning, you know, understanding areas that have none. Like, I can tell you with great certainty that there is very little in terms of hospice and palliative care penetration in like the east, the lower peninsula, east coast. You know, so how do you kind of have those ongoing kind of conversations? And to a lot of times palliative care and hospice care drive some of that education that you're talking about. So understanding where there aren't resources to be able to kind of have an alternative to care within hospital, that kind of thing. And it may be that, again, we have moved out of the lane of patient advocate designation. That these maybe are just beyond our scope. And if they are, then disagree.
Looks like this is going to take a little bit of extra time for people to go through and read it all and write in any answer. So going to give this one a little extra time. I don't want to rush anyone, but maybe we give this another 30 seconds and then just so that way we have time to go over the results as a group and wrap things up before the 5 o'clock hour. We will close this out. So I'll give it about another 30 seconds. All right, does anyone need any extra time or are we okay to end this one? Don't want to cut anyone off. All right, looks like I think we have just about everyone in now. So perfect. All right. Here we go.
Okay. 63% had long answers. So we want to kind of get into that. I don't know that we have the time to go through it, but we will capture all of that. Let's go through to the next one. So that one's kind of pretty decisive. Number 3 was ED visits in the last 6 months of life. Also fairly decisive. Okay, inpatient days in last year of life could be a good measurement for measure. Okay, good. Chemotherapy in the last 2 weeks of life might be 50-50 split on that. Family survivor satisfaction surveys could be a good measure for measuring ACP success. Number of patient advocate documents captured submitted on a month-by-month basis would be a good measure for measuring ACP success. Okay. Okay. So is everybody else is seeing the poll results, correct?
Yep, we're seeing them.
Yes, Lisa. Mhm.
Can we go to number 15 and see what kind of the long answers are there? Does anybody object to kind of jumping to that? We can also have conversation about it.
Yes, sorry, I was trying to scroll over. Okay, so for number 15, the answers written in. Use of CPT 1 and 2 ACP codes by providers. Track referrals placed. Actually, if it's okay, how about I throw this in the chat because it's a little bit long and I don't.
That'd be great.
Yeah, just that way you don't have to.
While you're doing that, I'll just make one anecdotal comment. I'm curious if it's true for others. It's astounding to me how many ACP documents we had where the provider didn't bother to put in a billing code. Just stunning. It's that testament to even when you're going to get paid for it, the one extra piece of work may be too much work. Or the uncertainty about whether or not you could document that more than half of your 60 minutes out of a 30-minute encounter, all those things. So I'd love it to be a good metric. I'm just not sure it is.
Sure.
All right, so I just put the 3 that were written in, or 3 comments that were written in into the chat. The first one is the bubble on its own, and then the second 2 are slightly shorter.
So percent of patients with legal valid ACP document, that is the main metric for the most important goal. So percent of total, I'm trying to think of how we would get to a percentage of population of Michigan, of population over 18 of Michigan.
Yeah, I mean, I'll jump in on it. That was my comment. All of that can be decided later, right?
Right.
So you could do everything depending on analytics, just simply by age, by people with known chronic conditions, whatever other data you might have, or even AI over time, right? So that's the opportunity out there. But the definition of, exactly what would be, what do you have data-wise that you could start with and then
Sure.
proceed, right? So it might start for a lot of people, it starts with just people over age 65.
Claim line limits are a factor for seriously ill patients. That's why we don't see it billed. Oh, meaning anybody that is not with Medicare, correct? Like if you're outside of a Medicare wellness visit, they may get charged for a separate copay, correct? Gina, is that what you're talking about?
No, in terms of data transmission on a claim, you can only get 12 diagnosis codes, 4 claim lines. So depending on what's done at a visit, there's limitations with how much you try to send across to insurance companies and how much actually gets transmitted over there. And then there's even EMR limitations and clearinghouse limitations that further whittle that down, that your intent might be to share all this information on a bill or whatever you put out the door, but it might not always make it there.
Especially when we're facing the exact same thing in terms of social documenting, like social determinant of health kind of factors, same thing, because there are some.
Yes, I always ask the question for social determinants. Do you want to submit a code that doesn't do anything, get me anything? Or do I want an HCC code that'll risk adjust and increase my RAF score? So same type of concept.
All right, very good. All right, we are 100% at our time limit. I thought we'd be out of here in like an hour, but not the case. So it proves to us that there is just a lot going on, that people are very passionate about this. I think I know our team greatly appreciates your ability to engage and provide the meaningful feedback. And we will, next steps for us, if anybody has any questions, comments, feel free to reach out to us. Next step for us is to take all of this vast information and recommendations, put it into something that's legible, be able to pass that up both to the HIT Commission and summarize kind of what we have done, available to our MDHHS partners, as well as to anything that is applicable to our MyHIN board. So as soon as we kind of have some of those, we can also share those with you. But greatly appreciate your efforts and your time and your engagement and your intelligence to help us out here. So thank you very much, and we appreciate it.